Bismillahirrahmanirrahim. In this video, we are going to discuss about the outcomes and morphological patterns of acute inflammation. The learning objectives for this video are to describe the key morphologic patterns of acute inflammation, including serous, fibrinous, suppurative, and ulcerative type of inflammation. We will also see what is cellulitis and also the pseudomembrane formation. To differentiate between various morphological patterns that are based on exudate composition, tissue involvement, and associated clinical condition, and to correlate each morphological pattern with its underlying pathology and clinical significance, particularly in terms of diagnosis and potential complications. The morphologic hallmark of acute inflammatory reactions are the vascular changes, edema, and the recruitment of more inflammatory cells to combat the inflammatory reaction. There are some vascular changes as well as there are some cellular processes. But the microscopic patterns of the inflammation are more particularly that depends on the severity of the reaction, specific cause of the inflammation, and the site and the tissue that is involved by this inflammatory process. There is diversity in the outcome of the acute inflammation, and there are many factors in the host as well as the nature of the inflammatory response. They determine the outcome. So if the injury that is the cause of this inflammation is infarction, bacterial infection, or toxins or trauma, there will be acute sort of inflammation that is marked by vascular changes, recruitment of the neutrophil in the presence of many mediators. So this acute inflammation that has developed now can have three major outcomes. One is the complete resolution. The inflammatory process will be cleared. There will be injurious stimulus cleared, clearance of the mediators and the cells that have invaded this area. There will be replacement of the injured tissue or cell, and the site or tissue attains normal function. So this is also termed as healing with repair. There is complete resolution and return to normal function. Or this injury, if it undergoes injury and inflammation, if undergoes into liquefactive necrosis, it may result in pus formation that is seen as an abscess, a localized collection of pus in a cavity that is lined by a pyogenic membrane is called an abscess. So there will be invasion by neutrophil that is present in acute inflammation. Some cells are dead, and there will be presence of necrotic debris and necrotic neutrophils also that are characteristic of these pus formation. This abscesses may undergo healing or directly, or there will be acute inflammation that will go towards the fibrosis or healing when there is a large area affected, and or there is a lot of fibrin that has gone outside the vascular compartment, and there is organization of this fibrin outside, and it is not cleared by the macrophages and other phagocytes. So this tissue will be invaded by fibroblast, and fibrosis will occur in this area. So this is termed as healing with fibrosis. Healing with regeneration, liquefactive necrosis, or healing with fibrosis are three usual outcomes of the acute inflammation. If the injurious stimulus is not cleared away, or there is viral infection or overstimulation of the immune system, as happens in autoimmune disease, this acute inflammation may progress into chronic inflammation that is marked by angiogenesis, that is new vessel formation, mononuclear cell infiltrate, and fibrosis. And this chronic inflammation may lead to fibrosis or healing with repair. This flowchart is summarizing the events. Acute inflammation may undergo resolution, complete resolution, that is the usual outcome, or if there is excessive exudate, there will be formation of suppurate, and this is suppuration and abscess formation. Abscess formation may directly lead to scar, development or formation of a scar. When there is excessive necrosis of the tissue, it will be be leading towards the repair and organization of this site, and there will be fibrosis. That is major hallmark of this condition. Extensive tissue involved damage. The primary inflammatory or acute inflammatory damage is more. There is a large area affected, so there will be fibrosis. Or if the acute inflammation is persistent, it will lead towards the chronic inflammation. So repair and organization can also lead to the resolution, but here this is the over here when there is excessive necrosis, there will be healing by repair, and usually there will be healing by regeneration. The morphologic patterns of acute inflammation can be divided into four patterns: the serous inflammation, fibrinous inflammation, suppurative or purulent inflammation, and ulceration. These can be memorized by mnemonic. Some friends share ulcers. S. Some serous inflammation, friends fibrinous inflammation, share suppurative inflammation, and ulcers ulceration. Some friends share ulcers. The serous inflammation is a type of inflammation that is characterized by the exudation of salpure and watery fluid that has been accumulated in spaces created by tissue injury or the these are developed in the body cavities that are lined by serous membranes. These body cavities may be peritoneum, pleura, or pericardium, and the source of fluid that is accumulated in serous inflammation may be plasma or mesothelial secretion. This ultrafiltrate is formed due to increased permeability of the vessel wall, or it may be due to increased secretion by the mesothelial cell after local irritation. The characteristic of this inflammation are low cellularity, sterility, and clear fluid or extraocular fluid. In body cavities, these effusion or collection of this cell poor watery fluid may be inflammatory and non-inflammatory. This can be non-inflammatory when there is increased hydrostatic pressure, and whenever there is increased hydrostatic pressure, there will be ultrafiltrate or transudation of the fluid from the capillary into the tissue, as happens in the heart failure. Hypoproteinemia will result in decrease oncotic pressure as seen in liver disease and kidney disease. So it also is responsible for serous inflammation. Another cause of this serous inflammation is thermal injury. So here in this microscopic picture or H&E stain, you can see that there is a clear-cut separation from the within the epithelium, or dermis is separated due to presence of this fluid within this area. Fibrinous inflammation is another type of the inflammation in which there is increase in vascular permeability, and due to this increased vascular permeability, large proteins such as fibrinogen exudate and escape into the tissue. These fibrinogen in the tissue, they are converted into the fibrin. So the large vascular leak or local procoagulant stimuli such as presence of cancer cell can lead to the this type of the inflammation, that is fibrinous type of morphological type of inflammation. So these fibrin can be cleared away by the macrophages. There can be activation of the for the fibrinolysis, and if the fibrin deposits they remain there, or due to their persistent, they stimulate the growth of the fibroblast, and also they they stimulate the new blood vessel formation, and this fibroblast growth will result in scar formation. One example of this condition is organization within the pericardial sac. This type of the fibrinous type of the inflammation is more commonly present in the uh, body cavities and in severe injuries. So in body cavities, the meninges, pericardium and pleura are the common sites for the fibrinous inflammation. Then histologically, there is presence of eosinophilic or pink colored meshwork of threads or sometimes amorphous coagulum. This may organize and form fibrous scar if not cleared away by the macrophages. These pictures showing the morphological appearance of the fibrinous inflammation. Here, in this picture, fibrin deposits are present on the pericardium, while the microscopic appearance of the fibrin is a pink meshwork of this material that is present over the pericardial surface. Another morphological pattern of this inflammation is purulent inflammation or suppurative inflammation, that is characterized by presence of abscess, and there is production of pus and exudate that consist of neutrophils, the liquefied debris of the necrotic cell, and edema fluid. So the cause of this morphological pattern of acute inflammation is pyogenic bacteria or pus producing bacteria. Pus producing bacteria, one example is Staphylococcus aureus. The terminology we often use is abscess, that is localized collection of pus in a tissue is termed as abscess, and empyema, that is collection of pus in a body cavity. So remember these two terms, abscess and empyema. Empyema, collection of pus in a body cavity, such as empyema thoracis, that means collection of pus in the pleura. Examples of this purulent inflammation are acute appendicitis and bacterial meningitis. The morphology of this abscess, that is characteristic of purulent inflammation, there is a central focus that is composed of necrotic leukocyte and tissue cell. This is surrounded by a preserved zone, and this preserved zone comprises of some neutrophil. Then there is a peripheral zone that is outside this preserved zone, and in this peripheral zone there is vascular dilation, parenchymal proliferation, and fibroblastic proliferation. So parenchymal proliferation and fibroblastic proliferation, they are characteristic of chronicity of this condition and an attempt for the healing. Sometimes this is ultimately this is resolved by scar formation due to proliferation of these fibroblasts. So these cross pictures are showing the purulent inflammation. Over here, the cut surface of the lung, this cut surface of the lung is showing numerous small yellowish bacterial abscesses that are seen in bronchopneumonia, and histologically the abscess is composed of the collection of these neutrophils. These neutrophils are that are present in the central zone, and there is presence of congested blood vessels that are surrounding these collections of neutrophils and dead tissue. Over here in this picture there is collection of this yellowish fluid, and this yellowish fluid is the pus or purulent exudate that is present near the heart. So another example of purulent inflammation. In this picture, the base of the brain is showing the pleural yellowish purulent exudate beneath the meninges, and this is a case of acute meningitis that is caused by Streptococcus pneumoniae, another pyogenic bacteria. Due to presence of these yellowish fluid, there is obscured sulci. This is a ruptured colon case. Over here, there is thick exudate that is coating the peritoneal surface after the rupture of the colon. This fluid can be obtained by paracentesis, and this may yield fluid with the properties of an exudate that are high protein content with many cells, mostly composed of polymorphonuclear neutrophils, and if you culture this, there can be presence of multiple organisms, especially the pyogenic one, pus producing organism. Ulcer formation is another morphologic pattern of acute inflammation. An ulcer is a local defect or excavation of the surface of an organ or tissue that is produced by sloughing or shedding of the inflamed necrotic tissue. So it can be defined as inflammation with local tissue necrosis and sloughing of the surface epithelium. The common site for the ulcer formation is mucosa or skin and subcutaneous tissue. The common sites in mucosa are mouth, GI tract, and genitourinary tract, and the skin and subcutaneous tissue ulcers may be seen in diabetes mellitus and in pressure sores. The morphology of these ulcers is the presence of necrosis on the surface, and in the base there is inflammation and granulation tissue formation. Histologically, superficial loss of the tissue and underlying acute and chronic inflammation are seen in the ulcer. So the example of acute stage is presence of polymorphonuclear neutrophil within the ulcer and dilatation of the vessels, especially at the margins and in the acute stage of the ulcer. Then in chronic stage, there is proliferation of the fibroblasts that results in scar formation, and the neutrophils are replaced by accumulation of lymphocytes, macrophages, and plasma cells. So this ulcers can be summarized as unroofed lesion with loss of lining. The morphology in here, it's showing the presence of an ulcer in the duodenum. Here is the ulcer crater that is seen in chronic as chronic duodenal ulcer, and here microscopically this low power view of this duodenal ulcer is showing that there is defect in the continuity of this epithelium, and in the base there is presence of inflammatory exudate. The ulcers that are one of the consequence of acute inflammation are especially seen on epithelial surface. So the inflammation destroys the mucosa as is seen over here, and there are loss of focally lost gastric mucosa, and this large ulcer and various uh, several small ulcers are also adjacent to the large one, and each of this ulcer is surrounded by area of redness that is called erythema, and there is a predisposition for the bleeding, pain, and even these ulcers extend through the wall that results in perforation in the in the GI tract. This stomach wall or the gastric mucosa is also showing an ulcer, and this ulcer over here, it is due to an underlying neoplasm. You can see that there is also loss of rugal folds that are normally present on the mucosal surface of the stomach. So these ulcers can be developed by mechanical irritation, as happens over here. Due to prolonged endotracheal intubation, there is development of subglottic ulcers. The mechanical ulcers can also develop, that are also termed as pressure ulcers, or decubitus ulcer can form on the skin over bony prominence in person who are bedridden for an extended period of the time. So here the microscopic appearance of esophageal ulcer is seen, and here you can see that there is presence of this stratified squamous epithelium over here, this stratified mucosa is present, but over here it is absent. This mucosa is absent and there is some underlying inflammatory stuff present. Microangiopathy is one of the long-term complication of diabetes mellitus. Over here you can see that there is a presence of ulcer. These ulcers are common in diabetic patients that who have bearing this disease for more than 10 to 15 years. The already amputated toes are also seen in this picture. One of the pattern of this inflammation, the outcome or pattern of the inflammation is pseudomembranous inflammation. This is the a distinctive form of acute inflammation that is characterized by the formation of a false membrane that is termed as pseudomembrane. There is denudation of the epithelium, plasma exudes on the surface, and overhead it coagulates, and together with necrosed epithelium, the plasma, the coagulum of the plasma, it forms a false membrane. So the false membrane is composed of necrotic epithelium, fibrin neutrophil, mucus and debris. So how it is developed? There is production of toxin by some organisms that lead to necrosis of the mucosa, and there will be inflammatory response to this necrosis, and as a result there is sloughing of the epithelial surface, and this sloughing of the epithelial surface together with the deposited material, it forms a pseudomembrane, and so we can say that the components of the pseudomembrane are sloughing of the surface, that is the necrotic tissue with inflammatory exudate. There will be shallow ulcer that are present underneath the membrane. So this pseudomembrane is not a true epithelial layer, and the common examples are colon, that in which there is a presence of this condition due to uh, use of certain antibiotics, and this condition is also seen in diphtheria in the pharynx and larynx. It can be memorized by pseudo, the P standing for patchy, S sloughed, E epithelium, U under, D debris, and O organism. So the mnemonic for this is pseudo, patchy sloughed epithelium, under debris, and organism. So these pictures are summarizing the pseudomembranous colitis. Over here you can see that there is presence of this greenish membrane over the colon epithelium and this colonic mucosa, and this condition is caused by cholesteroids that were previously termed as clostridium, especially the clostridium difficile colitis is the name that is given to this condition. And the endoscopic view, that over here you can see that this is the 10 mucosa, and this membrane is composed of neutrophil, dead epithelial cell and inflammatory debris, and microscopically this crypt is showing the volcanic eruption of the neutrophil. There is this volcanic eruption of the neutrophils from the damaged area. Sometimes cellulitis also develop in the acute inflammation. So there will be a diffuse spreading acute bacterial infection of the dermis, and subcutaneous tissue that is characterized by erythema, swelling, warmth, and pain. So there is diffuse inflammation of soft tissue resulting from a spreading effect of substances like hyaluronidase released by some bacteria. There is a spin break in the skin, and due to this break in the skin, there is bacterial entry, and the entry of the bacteria incites an inflammatory response. And infection is spread along the tissue plane, unlike abscess that localizes the infection. So over here, the infection spreads along the tissue planes. One example is the Streptococcus pyogenes that is more common, and there is rapid spread, while in pharynx and larynx, MRSA or methicillin resistant Staph aureus are responsible, and they may form abscess. So the resultant morphology is red, hot, swollen, tender skin that is often associated with the skin and with the fever and malaise, and the borders are in this lesion are ill-defined, unlike erysipelas in which there are sharp edges. The risk factors for skin break are trauma, cut, or insect bite. While there is diabetes mellitus, there is peripheral neuropathy that is associated with repeated unavailing trauma. There is immunosuppression, another risk factor, and chronic edema or venous stasis also contribute to the list of risk factors. If it is untreated, various potential complications arise, such as formation of abscess, infection goes or it propagates through the lymphatics, so lymphangitis develops, there is necrotizing fasciitis development, or fulminant sepsis. So these gross pictures are showing the development of these areas of cellulitis that have got irregular margin, and large area of the subcutaneous tissue is affected, that is marked with erythema, swelling, and tenderness of the lower leg, and also this is cellulitis of the hand. This table is summarizing the major pattern of the morphologic patterns of acute inflammation. There are four major patterns: serous, fibrinous, purulent, and ulcerative, and two specific or special conditions: pseudomembranous inflammation and cellulitis. The serous type of the morphologic pattern occurs in as cell poor watery fluid, and there is accumulation of this fluid in the tissue spaces or body cavities. The exudate type is protein poor or serous. Common examples are the common causes are burns, viral infection, and mild inflammation. And examples are skin blisters and pleural effusion. Then fibrinous type of inflammation occurs when there are large pores in the vessel wall that result in fibrin-rich exudate, and it may be due to severe injury, or it may organize and develop a scar. The exudate type is protein rich in this type of the morphologic pattern of inflammation. The common causes are severe infection and autoimmune disease, and examples are fibrinous, pericarditis, and pneumonia. Purulent and suppurative type of morphologic pattern, there is presence of pus with many neutrophil, necrotic cell, and fluid. And The exudate is purulent or pus containing. The common causes are pyogenic bacteria such as Staphylococcus aureus, and examples are abscesses, empyema, and bacterial meningitis. Ulcerative morphologic pattern of acute inflammation shows necrosis and loss of surface epithelium with underlying inflammation, and exudative type may be variable. The common cause are ischemia, trauma, and infection, and examples are peptic ulcer and diabetic foot ulcer. Pseudomembranous colitis or pseudomembranous type of inflammation is characterized by formation of necrotic layer or false membrane that overlies mucosa, and in this the exudate type as fibrinous, necrotic cell, and neutrophil are present. The toxin producing bacteria such as Clostridium difficile and Corynebacterium diphtheria are responsible, and examples are pseudomembranous colitis and diphtheria. Cellulitis shows diffuse, poorly localized infection of dermis and subcutaneous tissue, and the exudate is purulent or seropurulent. The causes are Streptococcus pyogenes and Staph aureus, and examples are soft tissue infection, spreading skin, and there will be redness. Thank you for watching this video. If you have any question, please write in the comment box. Thanks.